What's up, you grade 5 mobilizers? Welcome back to Me and My Friends podcast. In this week's episode, episode 3, we talk about, or we finish a question from last week's episode and expand on it a little bit. We talk about our thoughts on clinical decision making, and we finish the episode by talking about physical therapy and its role in the entertainment industry. What's up, guys? Welcome back to another episode of 3 PTs in a pod. That is our name. If we haven't been clear about that before, I don't know that we have. We do have a name. It is 3 PTs in a pod. It was thought of by our very own KP. How did that come about?
First contribution to the podcast.
First and probably only, honestly. I don't really remember. I blacked out probably. We were like texting our group about it, and we thought about like placebos as our name, but I think that's a better segment, and it has a lot of potential to be a really good segment. I love that name, and then we were kind of talking about like being PT students and PTs, and I was trying to think of like 3 amigos, something with 3 in it, and I'm like 3 P's in a pod, and then I'm like, oh fuck, 3 PTs in a fucking podcast.
Well, pod.
Yeah, and it was just like something that just came together. It's like when you make a really good joke at one time, and it's like I don't deserve the credit that deserves, but I'm glad that it worked out.
Yeah.
And you're also responsible for the
picture. I'm a big Photoshop guy. Me and my friends do it all the time.
Not that skilled, but
No.
I've
like
that's almost
like
makes it funnier.
Yeah, definitely
like
makes it
funnier.
But like I'm 5 shades lighter.
Yeah.
For some reason, Chris is darker than me.
I literally just picked like your first Facebook profile because I was like, I don't know where else to get pictures from them, and then I didn't even ask them if they wanted me to use that picture, and then I just put it on there. It's a work in progress, though. I think we might update it
to pay someone to do something nice.
Yeah, when we get that first check.
That first sponsor check.
Shout out to our sponsors.
Yeah, SeatGeek.
You got it right there.
Use the code 3PTs for a 5% discount on
at Alvernia basketball game.
You get 1 free pretzel if you use the discount code.
All right.
Yeah.
So that's our name, 3 PTs in a pod.
What's our name, Chris?
Oh, yeah. So I'm here with my friends Artem and KP.
Thank you.
I'm Chris. We are 3 PTs in a pod. So now that we have that out of the way.
You happy now?
Happy now. Along with the name, we also have some contact information for you guys. So if you want to send in questions or topics for us to cover, it is 3ptsinapod@gmail.com. I hope that's correct. I should probably check, but I think that's what it is. It'll probably be on the screen somewhere.
Where'd you come up with that email?
I don't know, dude. It took a while. I was like...
Should we put it up?
Start thinking.
I
3 P's in a pod.
Yeah, and then
you came up with that email separate from you coming up with
I
the
sent
name.
KP an email, and he was like, oh my god, that's a perfect
That's
name.
a genius idea. I'm totally going to take that.
All right, so that's good. That's where you can contact us. Another little plug, a little side project of mine. I put on the first 2 episodes my Instagram account, DPT Reality, but that was just a little side project I started as like a blog, Instagram, Twitter, just sort of similar to this podcast in terms of just giving you some entertaining stuff about PT school, first-hand accounts of sort of my experience with PT school, and any references or tools that I found helpful or interesting, passing that kind of stuff along. So if you have a few minutes and you want to check something out, it's at DPT Reality on Instagram, at DPT_reality on Twitter. And I also have a WordPress blog for some of the longer form pieces of content, and that is linked on my Instagram and Twitter as well. So you can check that out if you feel.
If you guys read it, let us know. I haven't actually read any yet, so let me know if it's any good.
A lot of support so far, so it's it'll be right up there with who are the big Instagram people for PT. We got
Jared Hall.
We don't want to give any free advertising, so we'll just go look at my shit and
Your boy.
And subscribe.
Yeah, subscribe, read, send it to your friends.
Joe, P, maybe something with a P.
Oh yeah.
Pat. Shout out to Pat Davidson. He's my favorite person. But we should probably talk about that one.
Yeah, that'll be a whole nother episode on its
resources.
own. Yeah, resources and people we like to follow. But so today I think we wanted to start with a question that we finished off with last week. I mean the listener questions are just flooding in nonstop.
You guys are
hard
really
to
can't
shout out
take
to our
them.
fans.
really hard to keep track of it all. Somehow they found the email address without us even
We should start
sending
like
it
a
out.
PayPal account too for like if they want to donate.
Yeah, if you want to
GoFundMe.
Yeah.
Go fund
Amazon
my
wish list.
education.
Yeah.
I only need $100,000.
Only 300,000 for the
Well,
three.
no,
It's got to
it's
support all of us.
Yeah, that's true.
So last week we had a question from James from Philadelphia, local guy.
Jimmy
Jimmy from Philly. Look at
Jimmy
that.
from Philly.
Congrats on the win last night.
Yeah.
Phil.
He
If
said,
we're calling that.
"What's up, guys? I was wondering if you guys could lay out a framework for how you would treat a non-traumatic orthopedic injury." So I think that's just like any general like shoulder pain, back pain, something not with like no structural.
Yeah, I don't think we really
deformities.
gave too detailed of an answer last
I
time,
don't
so we
think we
figured.
I don't think we gave. Any
Yeah, I don't know that
answer.
we got into it too
I think
much.
we decided to
I
wait for
dipped out
KP.
early, so
Yeah. There was kind
I
of
think
a
we're
lot
just gonna
going
let
on with
KP
that.
handle the whole thing. So
Yeah.
I could sum it up in a couple of words here. Let me see how many.
wait, let me guess.
I could sum it up in 3 words.
3 words.
3 words.
Oh, I know it.
So do I. Let's hear it.
Give it
You
to
want
him.
to? You want to guess?
Treat the impairments.
Bang, boy! Treat the impairment.
Now, there's like a second part to this that I feel like, how do you determine how you're gonna treat and what you're gonna treat
Reproducible sign.
Oh.
before that, or actually during it? What you found the reproducible sign, but then in your head you're like, okay, I'm gonna do this.
Treatment becomes the intervention.
The
examination becomes the intervention.
Yeah.
That's a 2-parter right there.
Literally, I want that tatted on my body because it's become so ingrained into you. And I think this brings it back to last episode, not to like retract, but it's sort of like how do you like learn like originally, and that's like something you have to know from the start. There's no straight answer. Every answer is it depends.
Mm-hmm.
Every answer is don't go buy a cookbook, which is good because physical therapy is not that.
But then,
like
90% of PTs just fucking.
Well, and I think it's changing too, which
I
would
do
be a cool.
think that as well.
I think we'll talk about that.
Hashtag new wave PT.
Yeah, we're the new generation.
Yeah,
boy.
dude.
But yeah, I think that should be like on the first slide of every first PowerPoint is like, don't worry about if it's a torn rotator cuff or like impingement. Treat the impairments if they're limited in flexion.
Treat what you can treat.
Yeah, but
Yeah.
I think
Gonna fix
that's
a
I don't think
rotator.
that's a known thing, especially with novice student PTs. Is like,
That
all
you
right, we
don't
got to worry
have
about like,
Where like
oh,
you overthink things.
should
Yeah.
I focus on what if they're uncomfortable in the prone position or like
Yeah.
so too many variables to think about. And I think maybe they don't tell us that originally for like just to prepare yourselves more, but something I wish I would have known, and I think that's something you really have to swallow at an early time. To be able to really learn from how to like treat the impairments is to like not worry about the diagnosis as much as their functional limitations.
Well, and like you said, that's what you're getting in school is your hopefully anatomy, kinesiology, biomechanics, stuff like that, which then allows you to be able to treat I mean, that's what impairments are. It's like deficiencies in those areas. So if you know that stuff.
Yeah, in that same note, not everything has to be like a pathoanatomical
Definitely.
For sure.
thing in your mind. Like
Yeah.
it's kind of like the functional side of things.
And I think it's important to know like the typical progression of like a rotator cuff tear, like how long it's going to take and what you might expect. But at the same time, it's not like by the book. This is what you'll see. This is what you have to do at week 2 on Thursday.
Everyone's
3
like
p.m.
everyone's an individual. Like they'll have their own like healing process. Like you can kind of like predict based on like the human organism, but not everyone's going to be exactly the same. And it's kind of like a N=1 experiment with every patient. It's your own like RCT.
Yeah.
So, and you kind of have to like, and that's where like clinical decision making comes into play, because like you can't again like follow a cookbook with every single patient. You have to know how to individualize everyone's treatment program based on their like healing times, based on their response to treatment.
So let's say this off this question, for instance, someone comes in, you're at like a clinical over the summer, they come in with knee pain. How would you guys like go about that? Like, how does this process play out in real time, like in the clinic as like a student physical therapist? Like, how would you approach that situation?
So if you're like familiar with like the FMS or like just Gray Cook in general, he has a thing called like the joint by joint approach, where he kind of like evaluates like the joints above, like all throughout the whole body, but like the joints above and below primarily of like the impairment. So like say like the ankle needs mobility, the joint above is the knee, which needs stability, the hip above needs mobility, the lumbar spine needs stability, the thoracic spine needs mobility. So like if you use that framework, you kind of like, okay, you assess like the knee, make sure like everything's good there, like make sure there's no like glaring mobility impairments or anything like that, or like structural deformities like a meniscus tear or anything. But then you also evaluate like the ankle, make sure you have adequate mobility at the ankle, adequate mobility at the hip and pelvis. Because if you're not checking like the joint above and below, you don't know like what's like defective like along like the kinematic chain. So like going through that and making sure they have like full movement options throughout that chain, and you know they have full rotation at the hip, well maybe not full, but like enough to do what they need to do. And then same thing with the ankle, make sure they have enough dorsiflexion. Dorsiflexion's a big one, especially with like squatting and stuff. If you don't have enough dorsiflexion, you'll see a lot of people develop knee pain.
Squatting's pretty functional. Right?
Yeah.
I mean,
that's a big movement to check with knee pain. But basically, I would just try to give them as many movement options as possible in their hips and their ankles, and even above in their back, because that could all affect like how the knee's moving and how the knee's absorbing shock. And then once they have those movement options, you just get them stronger. Build strength, build power, build capacity. Make sure they have enough endurance to maintain the like good positions and not fall back into like faulty movement patterns with fatigue. But I think that like that movement, like the movement options, movement variability, whatever you want to call it, strength, power, capacity, that's like your framework right there. And then knowledge too, like education. If you like, they have like weird like conceptualizations about like pain, and like they think they're gonna have pain forever. Like maybe add some patient education to that. That's probably where you would start, and then move into like the movement aspect of it.
So what about like the initial exam process? Is there a way you guys are most comfortable like tackling that, or
yeah, I think that
for that?
What you were alluding to was more like a advanced process. I know, and
not necessarily. I mean, it's what you would do. You would check.
Yeah.
You would check the range of motion. You would always screen the hip. You would always screen the ankle.
Yeah,
like
right.
It's not necessarily advanced. It's probably a different way of thinking from like what we usually are like used to seeing and learning. Is like, okay, if the pain's at the knee, it's because of the knee or whatever. But like it could totally be like in the back.
Definitely.
Sure.
Like if you're missing like hip rotation, like you could definitely be compensating with like motion through the spine.
But I mean, I think our professors always make the point
totally,
of like hip, ankle when you're looking at a knee above and below.
Like what I've seen before, like in the clinic, they don't necessarily like even think it's like that far. It's just like, okay, we're gonna do patella mobs and then strengthen the quad. But like it's, as we know about like strengthening the hips for like knee pain, like you're not strengthening the knee to fix the knee. You're strengthening like the stabilizers.
Yeah, and I think that's something that we might have learned outside of school too. Is you definitely learn a little bit here, a little bit there. But what we learned was you take a thorough history, you go mechanism of injury, any like underlying causes that maybe they had a knee replacement 4 years ago that they didn't just decided to not talk to you about. That's like crucial, and I think that's sort of primitive now to like think about now that we're second years, big bad second years. But we were taught that for a reason, and it's just as important as screening the hips and the ankles.
Absolutely. Well, yeah, like that's where you like rule out stuff.
Exactly.
Like, that's where like your differential diagnosis basically
Right. Special
starts.
tests and rule out, like you said, meniscal tears.
Yeah, like
everything
especially
like
like
that.
structural stuff, because you're not necessarily gonna be able to change like structure. You're not gonna fix a meniscus tear, but like you could again treat the impairments, treat what you can treat, and that'll most likely.
And that's where
get
physical
us
therapy becomes fun, because you're given this knee pain, and then it's like a question, and then it's like a riddle. How do you solve that out? Like a knee could be anything. It could be coming from the low back, causing the hip malalignment, causing the knee to suffer because the ankle's pushing up and the hips are pushing down.
Yeah.
All something that could be from like an off, I don't know, pelvis or something.
Yeah.
Something like
getting really crazy.
I'm just saying.
No, those are great points, I think, from both of you guys. I think I definitely agree, and I think it comes back to somewhat what we were talking about with, like, you don't want a cookbook, but I feel like it is important as like novice practitioners. Like, I feel most comfortable being new with set like frameworks at least. Like, you have to have a system that works for you.
Exactly.
That you can go off of to get to those other like more advanced areas within either that same initial evaluation or subsequent treatments. Like, you have to have your system of, I'm going to do a good subjective where I look for these specific things. I'm going to do my neurological screen. I'm going to do my, myotomal screen. Then I'm going to get into my range of motion, my manual muscle test, my special test. Now I have all my information, and then from that I can get more specific and advanced in terms of the techniques I use to assess individual like structures or areas of the body. But you have to have that initial like starting point to go off of with every patient, or else you're like just almost shooting in the dark. If you're like, each time I'm going to create this new system of like looking at this problem, and I'm going to do something different than last time. Like,
I think one of our professors, Dr. Wise, said it perfectly today. You have this toolbox, and when to use this and when to use that.
Yeah, you don't use everything at once.
Exactly. You have them in your arsenal to use at a specific time, but as you gain more knowledge, you're like, all right, I'm not using anything past over here. Now I could focus on, I've seen that before, like what did I do last time that worked with that patient? Skip like 3 steps, now you're working, instead of spending the whole hour evaluating them, or however long you have, you're able to even start treatment that same day and then get them invested into PT. And I think that's something huge that you can take away from at least like more experience in the field when you go on your clinicals and stuff. Really like try to speed up the process of eliminating stuff, ruling out stuff in your head, even if you're not saying it out loud. You're like, okay, I've seen that before. It's not really sounding like a meniscus tear, maybe like an ACL or something like that.
Sure.
Treat it differently that way. So
don't overcomplicate it. I think keep it as simple as you can.
Yeah, and it's gonna be frustrating at first because you haven't seen anything yet. So you have no idea what to expect. Knee pain, holy shit, it could literally be anything.
You always go back to treat the impairments. Like, if you know like your normal values for like joint range of motion and strength and things like that, like you know how to assess like a movement pattern. And like you see like a faulty movement pattern, or you see limited range of motion, that's what you can affect. So try to affect it and see if do you use your test retest. And see if it made a change. If it improved their range of motion, if it improved their pain, like you're on the right track, and just keep going with that. You don't have to get like super fucking crazy about it.
Yeah, because you can't fix a rotator cuff tear. You're not gonna surgically put the supraspinatus attached back to its insertion.
Unless you're a surgeon.
But not in the 30 minutes that we have with patients.
Right.
Here, so.
Well, and Artem, you made a really good point that I just saw this tweet yesterday that sort of backed up what you were saying. It's from Dr. Michael Chivers, who I think is...
Is he an FRC guy?
He is FRC, So his tweet was, often we speak of movement optimization by trying to repeat a chosen preferred pattern of task accomplishment. Movement optimization comes from having multiple options for task accomplishment.
That's FRC wrapped in a freaking nutshell.
Yeah, so that's big in PRI too. Like that's something I've been actually like looking in the research too, is like movement variability. So like there's like 2 types of movement variability. There's like endpoint variability and coordinative variability, where like endpoint would be like you finish a task at a different point each time, and that's not necessarily like important for us, but like coordinative variability is like as you're doing a movement, say you're like squatting, at every single rep, even if it looks the same, is actually like
Something's
like at a
different.
motor
Yeah.
control level is different.
Mm-hmm.
And like that's a big thing with overuse injuries, like tendinopathies and things like that, is a decrease in movement, like coordinative variability, shows like an increased risk of overuse injuries. So like
That's
for like
Makes sense, yeah.
jumper's knee or like patellar tendinopathy, they found that like basketball players that landed with the same like degree of knee flexion each time had more risk of overuse injury because they're stressing the
Mhm.
same
Same
structures
structures.
over and over again instead of varying
Yeah.
like the load they're placing on different muscles and joints.
Right.
And that comes down to like you're not going to put like some sensors on the person, like evaluate like the small minimal changes, but what you can affect is like the big ranges of motion. So again, like you check the range of motion, make sure you try to normalize that first to give them more options to move so you can offload or unload different structures, bones, joints, muscles.
Exactly. Well, and you're asking, I mean, the goal of getting a patient back to function is being ready to perform in a dynamic environment.
Yeah.
I mean, that's what life is.
Yeah.
Like, you're not performing the same, like, ingrained motor pattern over and over throughout the day.
You
have
don't
to
walk
have.
on a treadmill in real
Right.
life. You walk on
Exactly.
an uneven sidewalk.
So to kind of sum this up, you can kind of say that like our goal is to help our patients adapt to their environment because if they can't adapt,
Mm-hmm.
then they're kind of fucked.
Yep. Well, and I
the
think.
ability to
Yeah, you give them
Right.
the ability to adapt to
Right.
their environment. That's the most important thing.
Yeah. And I think off of that too, like sort of another point to all this with clinical decision making is taking the patient's input. you
Oh
know?
yeah, absolutely.
I mean,
that comes
that's
into play.
a
That's
huge piece of all this that I think some people, it could be easy to get wrapped up in the fact that I need to make all these changes and like this isn't working or this range is missing, but like if that has no connection to what the patient wants out of therapy or like if you're not taking that into account when you're putting together a plan and you know your treatment sessions each time, or you have to have the ability to make them understand how
I was
important
just
what
gonna
you're
say,
gonna
like, that's
work
where
on
patient
is.
education comes in
Yeah.
because if they only want like manual therapy, and you know like if they need something else, like that's where you have to educate them.
Why would they need anything else?
That's a good point. Oh, I don't know why I said that. Just move them.
Just fucking move 'em.
Grade 5.
And at the same time, you're worried about aberrant movement too. So it's not only like gaining as much mobility as possible. Obviously,
It's like a continuum. Like you have like super rigid,
Mhm.
like at one end you have like optimal like movement variability in the center, and then you have like hypermobility at the
Yeah.
end. So like because then like hypermobility, you have no control over your movement. Rigidity, you have no
but we can
movement
fix
to
that
control.
too. So we're trying to get
Yeah.
everyone down here,
But
just
honest,
expand their spectrum. a
Yeah,
little
it's
bit.
probably
that's a good
harder
way
to
to
treat
say it.
like a hypermobile because
Yeah.
the giving somebody more movement options or like more range of motion is definitely easier than teaching someone how to control their range
Yeah,
of motion.
definitely.
Yeah.
I would much rather. Exactly. I'd much rather just move the hell out of people. High
Show off my
velocity thrust,
hands.
Billy.
Show off those hand skills.
About to catch these hands. Cool. Yeah, that was actually
Got
a good,
pretty deep in
good
there.
Yeah,
discussion. I mean, that's
yeah. Yeah, I think
we
we're
solved
all on
out
pretty much the
PT.
same page with that.
Absolutely.
Any other just general pointers or anything in terms of clinical decision making for people in school, especially getting started with like first time clinicals or
I'm still not good. You won't be good until probably like a few years out.
yeah.
It's frustrating.
I don't think you'll ever like consider yourself good. I think
Yeah.
it's like one of those
Yeah,
things you're
that's
always,
true.
which is a good thing because you're always chasing like
Yeah.
Mhm.
you want to be like really really good, so you're always trying to get better and better and better. But like you're never gonna be like wow, I'm like really fast.
Yeah. Even though along that path you can tell when you're like more legit than you start. It's like you can,
and that's the best feeling. in
And if
fucking
you
world.
don't have that feeling,
Oh.
then that means you're not getting better.
Yeah,
right,
and that means you're not
exactly.
probably not doing enough to get better, and you're kind of shit.
Like I think it sort of hit me this fall when we were at our part-time clinical was I was just for the first time like in the moment with my CI like keeping up in
Yeah.
terms of like this clinical decision making and like
Yeah.
what we were seeing in the exam and what that meant and what we should probably do
Yeah,
because
and
of
then
that.
they'll
like,
tell you like, oh yeah, I would have done the same thing or something like that.
Mhm.
And you're like, okay, like I'm on
I'm
the right
starting,
page.
yeah.
Like,
Mhm.
I'm starting.
But-
And on the same point, no, there's no one right way to do anything. as long as you're able to justify it,
Yep.
your CI might not have done it that way, but it's like, all right, I see why you were doing it that way. I learned it this way, and then now you have two options for the next time you see the same thing. So
as long as you know and can explain what you're doing. If you don't know if you can't explain it, then you don't really know, and you're just kind of fucking doing whatever.
Yeah. Well, my teacher told me.
Yeah.
Side anecdote, real quick. This is embarrassing, but my last clinical, patient came with a meniscal tear, actually post-op, and we were trying to get knee flexion back. So she was limited in knee flexion. So I was like, I'm just going to do a quick, mob. I thought it was like a hot shot. Ended up doing a superior patellar mob because I was like, the patella glides superiorly during knee flexion. Did that for about a minute and a half. Rechecked it again, gained 8 degrees of range of motion back. Went to tell my CI, I'm like, dude, it was awesome. I did some superior patellar mobs, got 8 degrees of flexion back, and he's like, why'd you do superior patellar mobs? I'm like, because the patella goes. I'm like, oh fuck, you're supposed to do inferior for flexion. He's like, yeah. He's like, but it worked, and that's why I said to him, he's like, yeah, I don't know why, but it did work. So
that was our placebo segment for
Boom.
this week. It's just a non-specific fact.
Yeah.
You put your hands on a patient, you got him to relax.
Yeah.
Got some neurophysiological.
It was a long day. It was.
Dude, if you don't have at least
half the
10
time
of those things, in a 6
dude, I tell everyone about that because I think it's hilarious.
Yeah, we've all fucked up.
Yeah.
We've all had questions, dumb questions that we couldn't answer.
Oh yeah, my God. It's such a different environment being out in the clinic and having to know things in real time. When you're in class, you have, in our case, 28 or whatever other people who are there to answer questions. If you're in the clinic, it's just you.
Yeah.
You have to know all those things and in real time within a conversation and not just let me look at my notes for 3 minutes and then I'll add into the discussion.
And now I'll never forget that.
Right,
so I'm glad I learned it that way.
Dude, that is
when
the
you
biggest fucking thing.
When you get fucking stumped and you're so in your head you're so ashamed of yourself, you're like, fuck, I can't believe
my God.
I didn't know that. You'll remember that forever. You'll
dude.
never forget that. And that's that's a great thing. You'd want that to be more often.
Yeah.
So that's not nothing to be ashamed of or disappointed.
And I was treating the impairment anyway, so it's not like I did it. It wasn't malpractice at all because I helped range of motion. So
you got what you were there for. So.
Yeah. We'll have to have a segment at some point in an episode and talk about our funny mistakes.
Yeah, I've never made a mistake.
Well,
you guys
can
talk
okay,
about,
all right,
about
all
your
right.
mistakes.
You're just ugly.
I was a mistake, actually.
God, you guys both beat. My whole life was a
my
mistake.
my mom's gonna come in and talk about that.
I made one horrible mistake.
It's
horrible. There's blood everywhere.
So, you were saying any advice to make it simpler? Honestly, write out your model or your framework for what you think is a good order or model for treating a patient, and then kind of discuss it with some people and see if they agree or they have any input, what they would add in or take out, and then refer to already established models. Refer to FMS or SFMA and see what they do, see what Greg Cook says or Mike Reinhold says, and kind of evaluate what you have, and then add or subtract stuff that isn't necessary or is necessary.
Completely agree. Yeah, I mean, if your program's doing what it should be, they should be giving you that framework to go off of, or at least have as a initial framework, and then, like you said, just from other resources and other people, even other, CIs, you pick and choose sort of what things make sense to you and what things work well for you, and kind of build your own system. I think that's sort of what you should always be working towards. And then once you have that system in place, always be working to perfect that system or improve it based on the results you're getting with patients. You have to be organized and have a system in place, I think, to be able to.
Yeah, well, that's just going to make it much easier for you, because then it's a step-by-step process, and then anything outside of that will kind of expose you to new material that you need to cover or things like that.
And you can't be, you have to be willing to put in work outside of the time you're in your clinical. You know, at night, if
Absolutely.
you go in and you just fucked up that day, like you should go back and look at that, you know, because you're going to probably see that patient again on Thursday, you know, and at that point you don't want to be making the same mistakes. I guess that's the thing. It's like make the mistake, but then don't make it
Yeah.
again.
You have to make a mistake at
Yeah.
once.
Yeah.
But
Mhm.
You don't-
as long as you don't make that or try not to make that mistake multiple times, then you're learning.
Right. That's exactly. That's learning.
There it
Sheesh.
is.
Dude.
That was pretty fucking deep. Do we
I
need
think-
a break?
I'm sweating, honestly. It's hot as shit in here.
Yeah, dude, this room is fucking hot. Yeah, so I think that is pretty much our clinical decision-making spiel. Some
That about covers it.
personal thoughts,
What
some
else we
tips.
got here?
That was it.
That's about it. I think we were gonna finish. What were we gonna finish with?
I think that was a clinical decision.
That was it?
Our last segment.
No,
Yeah.
we're going to talk about PTs and
Oh yeah,
Entertain-
PTs and entertainment. This
Oh,
is
shit, I
this
didn't
is
write that down.
a
God, I forgot.
topic we were
talking about.
No, I just
So these are the types of things that come up while we're in like break during class or something, like
Oh.
the big philosophical questions of the profession,
Yeah.
you know, of physical
Thinkers.
therapy, and just really getting some time to
Yeah.
dive into deep thought about some of these things. So
Yeah, modern day Socrates. Honestly.
yeah, I mean, so physical therapy as a profession, you know, not really well represented, I would say, in the entertainment field.
Definitely
Yeah.
not, unfortunately.
Plenty of shows about doctors, nurses. You got like Grey's Anatomy.
ER.
got
The Good
ER.
Doctor.
Scrubs,
Good
The
Doctor.
Good Doctor.
Where is physical therapy?
Where's the
this,
great physical therapist?
I
Right,
feel like
show?
a Good Doctor spinoff could be about PT, you know?
Yeah.
Like the okay.
We're doctors.
The
so-
okay physical therapist.
The okay.
Yeah, he's okay. He's okay. He's not gonna kill you. but
Charlie Sheen's like a main character.
But honestly, I mean, I don't know what it is. Why?
Well,
I mean, I
it's-
guess there's a lot of professions that aren't really.
I feel like people like don't even know what fucking PTs do.
Well, that is an
like
issue.
like
yeah.
we just do like a really bad job of exposing people to what we do and like what our profession's about. Like I swear, most people think that like PTs just do like massage and modalities.
Yeah.
Like when you hear that, like you'll be like, "Oh, what do you guys do? Like you do like massages and stuff?" Yeah, dude, that's what I do. Like I'm a fucking masseuse or I'm a personal trainer.
Yeah. Well,
You
that,
know?
that's There's the PT
I'm a goddamn
issue.
physio, for Christ's sake.
Yeah.
I was
right.
watching Seinfeld the other day, and they were talking about physical therapists. Actually, so we did have
Really?
one
Okay,
name
so
drop
I'll
on a
take
pretty
Seinfeld.
pretty big
Dude,
show.
One of
But
the best of all time.
unfortunately, he was getting a massage.
There you go. Well,
But that was also like 15, 20 years
True,
ago.
the
so-
field
and
has
it still
advanced.
hasn't gotten better.
But have there been any like references to physical
No.
Well,
therapy?
I was telling you
in,
guys, like in the one episode of Black Mirror, one of the main characters is a PT, and like they show her in the clinic doing some like rhythmic stabilizations with like a rotator cuff patient
Yeah.
or something. No,
No.
unfortunately.
We'll get there one day.
But
We gotta
that's,
start
I mean,
somewhere.
that's a step up from a massage in Seinfeld, little rhythmic stabilization.
We can blame our forefathers for that.
We are the
The
new.
shake and bake.
Yeah. Dip and dangle.
Yeah, that's all people know us for.
All right,
Yeah.
so we're gonna make a show then.
Yeah. Make a show.
So
That's
should
our
we-
next project.
Should we drop
Three
out now?
PTs in a pod.
3 PTs.
Anyone want any studios want to host us?
WB.
Who wants to direct?
Should we just go right for the movie or make it a little short mini series?
That'd actually be hilarious if we had like a sketch show, like a PT sketch show.
That's what this will just become.
Yeah.
It'll just be us acting in here now.
In here.
We'll just this is our treatment table.
Yeah.
You're the alien.
With like the crowd.
I
laughing
think
in
one of the
background.
issues, though, too, is that there's only such an audience for like
Yeah.
physical therapy.
Yeah.
Like, who outside of like physical
Doctors are
therapists-
sexy.
Outside
Physical
of-
Yeah.
therapy is not sexy.
No,
Yeah.
not enough.
Yeah.
Yeah, right. Needs
Maybe
to
we
be.
got to show a little bit more skin.
Yeah.
Maybe
tight polo or
we
something.
gotta,
Yeah.
we gotta get our. Maybe let's just start wearing our stethoscopes around,
Yeah.
or just like
Dude.
a goni,
Yeah.
because that's
Yeah,
our like that's our differentiating factor.
Yeah.
Like doctors, nurses have.
Going in the back pocket.
Yeah.
Yeah.
Stethoscope around the
Or
neck.
do
and,
a front pocket goni.
Oh yeah.
Jeez.
Like a
dude.
sword.
Show 'em.
That's where the timer goes.
The timer. Have a whole tool belt.
Batman. Yeah, you have like you wear Wrangler jeans with the hook.
Yeah,
and the loop for the
that's where
hammer.
your goni
And you
is.
put the goni in there.
What else
Oh.
we got? What other tools can we differentiate us? I don't even know. What
Doctors use blood pressure.
Well,
uneven.
We've got I asked him.
Oh yeah, some blades. Put
Well,
some blades
some
in there. You
blades.
might
You
get
could do
arrested
some
for that
damage
shit.
with that.
I see a sponsorship coming on too. I
Apocalypse.
won't name drop.
Apocalypse, let us
Well,
know.
Artem's gonna name drop.
You know, just in case, we're open to any sponsorships, any sponsorship
Literally
opportunities.
anyone. If you give us $1, we'll shout you out. Send us a T-shirt or something.
I guess that's it.
Yeah, I think we could wrap it up. Guys, don't forget to email us 3ptsinapod@gmail.com. I'll write that down at the bottom of the screen. You can follow us. That'll be on the bottom of the screen as well.
Yeah.
Any last words?
I don't
Keep
think so.
keep the questions flowing.
Yeah,
we had
just-
too many
I
this
mean,
week.
Yeah, it's been.
Yeah.
Unfortunately, we couldn't. We had a busy Easter break.
Yeah.
I couldn't.
Too much Fortnite. I couldn't get to the questions.
I just could not read any more questions, but awesome questions. Keep them coming. You guys are
Yeah.
awesome.
We
That
appreciate
was
all
my
you
mic.
guys.
Yeah,
Thank you
I
for
mean,
watching.
Crazy #1 podcast
Yeah.
on.
Yeah.
I think some. Who had us
in the
number
category
one?
of
New York Times.
three
New York Times.
male co-stars within the health and fitness field, subcategory physical therapy, we're number one.
in the greater
In the,
Philadelphia area.
the
Yeah.
greater Philadelphia, it's
Yeah.
crazy.
Something like that,
There's got to
yeah.
be like thousands
At
of them,
least of that.
Yeah, oh,
probably
yeah.
a billion.
and
This
we're,
is-
we're on top of the chart.
A hotbed of sorts. Central
Yeah.
Pennsylvania
Oh,
physical therapy.
Oh yeah.
So to be at the top of that category
Feels good.
is, yeah.
Humble
Grateful,
pie tastes really
humble, yeah.
Thank you guys.
We'll try to stay humble, and
No promises, but we'll try.
yeah.
All
All right, catch us next week, episode 4.